everybody, Dr. Ryan here again. Hope you and your family are well. Thank you so much for joining me, even as we are exploring an examination of our beloved thyroid gland and a clinical approach to hyperthyroidism today. So here's the outline of our talk. We're going to be covering a clinical case, and then we're going to look into history taking in thyroid disease, an approach to examination of the thyroid gland, and looking into thyrotoxicosis and outlining the different etiologies behind it, investigations and diagnostics, different modalities of treatment, and our beloved thyroid storm. Then, of course, we're going to have some encouragement from Scripture. So, as always the case, we start off with a lovely clinical case right here. We have got a 45-year-old gentleman is evaluated for anxiety, palpitations, and diarrhea, and found to have Graves' disease. Quite a grave diagnosis, that. So before he begins therapy for his thyroid condition, he has an episode of acute chest pain and presents to the emergency department. Now, although a CT angiogram is ordered, the radiologist calls to notify the treating physician that this is potentially dangerous. Oh dear! So which of the following best explains the radiologist's explanation? That A, iodinated contrast exposure in patients with Graves' disease may actually exacerbate hypothyroidism. That's looking a little bit juicy right there. B, pulmonary embolism is extremely rare in Graves. C, radiation exposure in patients with hypothyroidism is associated with increased risk of subsequent malignancy. D, tachycardia with Graves limits the image quality of CT angio and will not allow accurate assessment of pulmonary embolism. Or is it E, the radiologist was mistaken, CT angio is safe in Graves' disease? I wonder. Here's a picture of this gentleman. As we can see, some prominent exophthalmos. All right, and he looks kind of anxious, doesn't he? Okay, guys, so on the history, important questions to ask about suspected hyperthyroidism. Right. So have you had any history of thyroid problems? Is there a family history of thyrotoxicosis? As there is a familial incidence of Graves and association of autoimmune conditions, they tend to stick together in one family, all your autoimmune family. So inquire about autoimmune conditions like vitiligo, Addison's, pernicious anemia, type 1 diabetes mellitus, myasthenia gravis, and premature ovarian failure. Then ask if the patient has been on amiodarone or thyroxine, because both of these, as we know, amiodarone is infamous for it can cause either hyper or hypothyroidism on the back of the Wolff-Chaikoff effect or the Jod-Basedow phenomenon, respectively. Have you had any recent exposure to iodine? So iodinated X-ray contrast materials can indeed precipitate thyrotoxicosis, usually in patients who have an existing mastological goiter. Then ask, have you had any palpitations? Because indeed, atrial fibrillation can happen in the context of thyrotoxicosis, which can precipitate heart failure. Then have you ever noticed any insomnia, irritability, or hyperactivity? Have you had any loss of weight, diarrhea, or increased stool frequency, increased sweating or heat intolerance? Have you had any muscle weakness? Very important, because proximal muscle weakness is common, and the patient may have noticed difficulty in getting out of the chair or difficulty reaching for a high shelf, or maybe hanging up clothes because of weakness of the pectoral and pelvic girdle muscles. Then ask about eye problems such as diplopia, grittiness, redness, or pain behind the eyes. Alrighty. So let's get going, guys. Examination of the thyroid. First, you want to introduce yourself. Hello, my name is Dr. So-and-so. How do you do? And while shaking the hand, check whether the hand is warm and sweaty, which speaks to thyrotoxicosis, or is it cold and sweaty, and that speaks to anxiety neurosis. Then look at the patient's face. If the patient looks anxious and restless and fidgety, or has a frightened face with staring looks, as in our clinical case, you're thinking about thyrotoxicosis. If the patient has a puffy face with periorbital swelling, baggy eyelids, and loss of the outer one-third of the eyebrow, something we affectionately term Queen Anne sign, and the patient just looks apathetic, right? Thinking about hypothyroidism. The patient has obvious exophthalmos, which can be uni or bilateral, thinking about Graves' ophthalmopathy. If the patient has a normal face but with a goiter, you're thinking about a euthyroid goiter. Then you want to inspect, palpate, and auscultate that thyroid gland. Yeah. You're just looking at the anatomy of the thyroid gland together with the surrounding structures. So you can see the cricoid cartilage here, and the thyroid gland sits on top of that. So there's the isthmus, and then we have the right and the left lobes, and sitting on top of those are the beloved parathyroid glands. Alrighty. And this is showing us how we palpate the thyroid from behind. Okay, here's an example of toxic multinodular goiter. You can see this patient is extremely cachectic in the setting of thyrotoxicosis, and this is what we call apathetic thyrotoxicosis. All right. So you want to inspect the thyroid, inspect the neck from the front and left and right sides. So first up, you check for any obvious swelling, which speaks to a goiter, and ask the patient for deglutition, which is a fancy way of saying swallow. Okay, we are guinia, right? Swallow. Offer a glass of water, then ask the patient to drink it. If there's any goiter, you check whether it's diffuse, single, or multinodular, and check if one side is larger than the other. Right, so that will probably lend itself more to multinodular goiter or a toxic adenoma, as opposed to a diffuse enlargement of the thyroid, which probably will speak to Graves or thyroiditis. Right. Look at the skin color, the overlying skin color. Redness, as we know, indicates an infected thyroiditis. Look for any scar, which could be there because of previous surgery, and other obvious swelling, such as lymphadenopathy. All right, so here we can see a whole lot of different kinds of goiters. Alright, so here we see diffuse enlargement of the thyroid gland. This is the anterior view, this is the lateral view, right, versus a uninodular toxic goiter here, which is the toxic nodule, and this is multinodular, right, a multinodular goiter. Alrighty, here we can see a lid lag being demonstrated. So you ask the patient to follow your finger and you move it in an arc from top to bottom, and you'll be able to see the sclera, above the iris. Alright. This is lid retraction demonstrated here, pretibial mixed edema. Just move this out of the way, and onycholysis in Graves' disease, which is essentially separation of the nail from the nail bed. Alrighty, more and more pictures. Here's Graves' disease. We've seen this in our clinical case. This is mixed edema, non-goiter. So there's no goiter, but the patient just looks apathetic, loss of the outer third of the eyebrow, the face looks puffy, right? This is Graves' disease, right? The hypothyroid phase, and this is mixed edema. Right. Alrighty, more pictures. So here's the typical facies we see here in image A, typical facies of Graves' disease. We can see the prominent exophthalmos. There's kind of nervous or staring expression. Right. B shows us severe inflammatory thyroid disease, right, with swelling of the caruncle and conjunctival changes. Alright, together with a degree of exophthalmos. In picture C, we see thyroidopathy, which is basically clubbing in the setting of thyroid disease. And here we see the typical pretibial mixed edema, which speaks to Graves' disease. All right, then you want to palpate the thyroid gland from behind. So you ask the patient to sit and show the neck is slightly flexed and palpate the gland with both hands and ask the patient to swallow again. If goiter is present, you want to check at this point whether it's uni or bilateral, whether it's diffuse or nodular, that is single or multinodular, and then examine for the following points. Right, let's just get my pointer in there. So you want to check the size. Ask yourself, which is larger? Is it the right lobe or the left lobe? Then the shape, is it diffusely enlarged or is it irregular? The surface, describe it as smooth or irregular. Consistency, is it soft, firm, or hard? Tenderness, if present, indicates subacute thyroiditis or infected thyroiditis, right? Check if it's mobile, if there's any overlying skin changes and fixity or redness, and check the lower margin to ascertain whether there is indeed retrosternal extension of that goiter. Right, and how do we examine for retrosternal extension? Well, you may see prominent veins in the neck and in the upper chest. Feel the lower limit and check for tracheal deviation. Percuss the upper part of the chest for dullness and examine for our beloved Pemberton sign, right, which often speaks to a superior vena cava syndrome or a thoracic outlet obstruction. You ask the patient to lift the arms for at least 60 seconds, and what you're going to see is non-pulsatile elevation in the jugular venous pressure. You're going to see facial plethora, and the patient may become stridulous, right? Palpate the cervical lymph nodes. If palpable, these may indicate metastases, and feel for the beloved carotid pulse. Absence of pulsation in the setting of a goiter indicates pressure effect or malignant infiltration. So here is just showing the technique of how you're going to palpate the thyroid from behind while the patient swallows sips of water. Right. So what are the possible causes, guys, of thyroid nodules? I'm glad you asked. Well done. So first up is the dreaded carcinoma, which accounts for 5% of palpable nodules. And the characteristics of this is that those nodules tend to be fixed to the surrounding tissues. They are palpable lymph nodes, vocal cord paralysis. They are hard, especially if larger than 4 centimeters. Portends a diagnosis of carcinoma. Other possibilities are adenoma, which tend to be mobile with no local associated features, a big old nodule in a multinodular goiter, in which case you would have a palpable multinodular goiter. Guys, the causes of goiter in general, we can partition or stratify them into a diffuse goiter or a solitary thyroid nodule. The causes of diffuse goiter can be idiopathic, which is the vast majority of them really, puberty or pregnancy, thyroiditis, and then we have Hashimoto, subacute, where the gland is usually tender, simple goiter, speaking to iodine deficiency, and of course goitrogens, like iodine excess and drugs like lithium. There's also some inborn errors of thyroid hormone synthesis in the way of Pendred syndrome, which is autosomal recessive and associated with nerve deafness and thyroid hormone resistance. Causes of solitary thyroid nodule are split into benign and malignant. So benign, it could be a dominant nodule in the setting of a multinodular goiter. It could be degeneration or hemorrhage into a choroid cyst or nodule. It could be follicular adenoma or a simple cyst. But malignant flavor comes in either carcinoma or lymphoma, and the carcinoma can be either primary or secondary, which is somewhat rare. Finally, you ask the patient to hold their breath, and you will auscultate for a beautiful thyroid bruit. Also for a carotid bruit and a venous hum, which can be obliterated by gentle pressure at the base of the neck. If the thyroid bruit is indeed present, check whether there is the murmur of aortic stenosis, an ejection systolic murmur, radiating from the chest, because that is a differential for that sound. Remember, in our video about aortic stenosis, we said that the murmur is ejection systolic and radiates up into the carotids. Thereafter, you want to examine the thyroid status, the eyes for orbitopathy, check for pretubercular mixed edema, listen to the heart for evidence of heart failure, especially in the lungs as well for bibasal crepitations. Guys, we alluded to Pemberton's sign before, but what really is Pemberton's sign? It is a sign to detect retrosternal extension of the thyroid gland. It's also positive with any retrosternal mass, right? So like we said, you ask the patient to raise both arms above the head, and patients with retrosternal extension may develop the following signs of compression. So there'll be, in the face, there'll be suffusion or congestion and cyanosis. There'll be respiratory distress, and the patient often becomes stridulous. The neck veins become engorged, and the patient may complain of dizziness and may develop syncope. This sign is rare, but is not specific for retrosternal goiter. Please note the following points, guys. You must look for eye signs of thyroid disease, which speaks to thyroid orbitopathy. We'll be talking about the way to stage eye disease shortly, right? But you look basically for exophthalmos, for periorbital edema, for chemosis and diplopia, pretubercular mixed edema, and thyroidocropathy. That particular triad of eye signs, pretubercular mixed edema, and thyroidocropathy is what we term Graves' disease. However, lid lag and lid retraction are more general eye signs, and they are not specific to Graves'. They just occur in any condition where there's thyrotoxicosis, and it's due to sympathetic overactivity, which supplies the levator palpebrae superioris muscle. Okay, thyroid bruit is present only in Graves' disease. So other findings in the hands of thyrotoxicosis, palmar erythema, onycholysis, we saw a picture of that, and that's what we call plumicine, right, which speaks to separation of the nails from the nail bed. And of course, clubbing, which is a acropathy, happens only in Graves' disease. Exophthalmos and pretubercular mixed edema do not correlate with toxicosis. It may be present both in hyper or hypothyroidism, or even in the euthyroid state associated with Graves' disease. All right. So this is a beautiful diagram from Macleod showing us the important differences between hyper and hypothyroidism. So in hyperthyroidism, remember we have eye signs, so exophthalmos, ophthalmoplegia, especially in Graves' disease. We say Graves is going to be a triad of pretubercular mixed edema, thyroidocropathy, and eye signs. You're going to have a goiter with a bruit in Graves' disease. In the heart, we have tachycardia, angina, and atrial fibrillation, together with systolic hypertension, oligomenorrhea. Remember, so in hyperthyroidism, your menses get less frequent, okay? Diarrhea, sweaty, tremulous, and warm hands. If those hands are cold, that speaks to anxiety neurosis. Proximal myopathy, so difficulty waking up from a seated position, difficulty raising the arms above the head, all right, ankle swelling, and heart failure. And in general, patients with hyperthyroidism have weight loss despite increased appetite. They have heat intolerance, anxiety and irritability, and a fast, fine tremor. Versus the situation in hypothyroidism, which we'll talk about in our next video. But essentially, these patients have periorbital edema, they have the Queen Anne sign, they have a husky voice, goiter, bradycardia, carpal tunnel syndrome, and other intrapid neuropathies, menorrhagia, and constipation. And in general, they have a low metabolic rate with weight gain, sensitivity to cold, lethargy, mental impairment, and depression. Okay, this is a nice, funny way to represent the features of Graves' disease, courtesy of our colleague George Munoz over at medcomic.com. God bless you, sir. So here we can see what happens in Graves' disease. So grave, because this guy is called Gary Goiter, and this is his grave. Right, we see a lady looking at his hand coming off from the ground. She's getting obviously very anxious. So she has a tachycardia, an arrhythmia, she has diaphoresis, tremor, and her eyes are bulging out, speaking to exophthalmos. She crept on the ground, speaking to loose stool, right? And Graves is indeed the most common cause of hyperthyroidism. It is an autoimmune disorder that can result in overproduction of thyroid hormones, typically affects women of childbearing age, 20 to 40 years old, alrighty? Guys, the differential effects of ophthalmos is quite broad. So bilateral exophthalmos is due to Graves' disease, but unilateral can be due to tumors of the orbit, cavernous sinus thrombosis, right? Graves' disease and pseudotumor of the orbit. All right, so here is the clinical activity score we were alluding to earlier for Graves' orbitopathy. It's scored out of 10. It's split into or certified into 4 different areas. Talking about, let's just get my pointer in there. Talking about pain, redness, swelling, and impaired function. So under pain, you get 1 point for painful, oppressive feeling on or behind the globe during the previous 4 weeks, and also on pain on attempted upside or downward gaze during the last 4 weeks. Redness, we speak to redness of the eyelids, diffuse redness of the conjunctiva covering at least 1 quadrant, right? In terms of swelling, we talk about swelling of the eyelids, chemosis or swollen caruncle, an increase of proptosis by at least 2 millimeters during a period of 1 to 3 months. And then, of course, points 9 and 10 have to do with impaired function. So in that there's a decrease in eye movements in any direction during a period of 1 to 3 months, or diminished visual acuity. Right, for each item that's present, 1 point is given. The composite sum of these is the clinical activity score. In general, if your score is 3 or more, that mandates the use of steroid therapy, usually pulse steroid therapy. There's a beautiful article here entitled Current Concepts Regarding Graves' Orbitopathy, taken from the Journal of Internal Medicine. Alrighty, and here they say, they outline current concepts regarding Graves' orbitopathy. And of course, they outline important risk factors for Graves' orbitopathy. And then we have smoking, radioactive iodine, TSH receptor antibodies, dyslipidemia, oxidative stress. And we said that with mild Graves' orbitopathy, selenium is all that you need. Right, but with severe active Graves' orbitopathy, we opt for IV glucocorticoids and the neurobiological agents. All right, other second-line treatments one may consider, right, besides mycophenolate mofetil includes, so you mentioned the IV glucocorticoids, then you give your oral glucocorticoids and taper, right, together with either cyclosporin or azathioprine for steroid-sparing effect, or you can use monoclonal antibodies, the likes of rituximab, tocilizumab, teprotumumab. Okay, so let's ask some more questions, everybody. Mention causes of painful thyroid swelling. So subacute thyroiditis, otherwise affectionately termed de Quervain's thyroiditis, radiation thyroiditis, and of course infective thyroiditis. This causes of a painless thyroid swelling, Hashimoto, and postpartum thyroiditis. What are the causes of thyrotoxicosis? There's a whole truckload of them. So in 76%, guys, quite common is Graves' disease. All right, and coming up a close second is toxic marginal goiter at 14%, but maybe not that close. Toxic marginal goiter, toxic nodular goiter follows, in that 5% in the way of toxic adenoma or a hot nodule, speaking to plumber's disease. Then we have thyroiditis, where we speak to the subacute thyroiditis, like we said, it's called de Quervain's thyroiditis or postpartum thyroiditis, right? Hashimoto's follows initially, but remember that it runs a biphasic course. So initially you have thyrotoxicosis, and then later on you have hypothyroidism. Factitious thyrotoxicosis in the way of patients with self-administered thyroxine. Then we have iodine-induced thyrotoxicosis called the Jod-Basedow phenomenon, and drugs like amiodarone. Other rare causes include carcinoma of the thyroid, being follicular thyroid cancer, struma ovari, which is ectopic secretion of thyroid hormone, and hydatidform mole and choriocarcinoma, because both secrete a compound that's remarkably similar in chemical structure to thyroid stimulating hormone. Guys, please note that if any patient complains of weight loss despite good appetite, the likely diagnosis is thyrotoxicosis. The other possibility is diabetes mellitus, so always keep this in mind and screen appropriately with your appropriate oral glucose tolerance test, fasting and 2 hours post, and your HbA1c, your glycated hemoglobin. However, loss of appetite in thyrotoxicosis may also occur in the elderly. So what investigations you're going to do with thyrotoxicosis? Let's talk about that. First up, test of thyroid function, right? So you do your bloods, you look for a T3, T4 level and a thyroid stimulating hormone level. A low TSH with a high T3, T4 speaks to thyrotoxicosis. In T3 toxicosis, the T3 is high, but TSH and T4 are normal or near normal, okay? Then you can do a radioactive iodine uptake test, which demonstrates rapid uptake and rapid turnover. High uptake in about 204 and 24 hours and rapid fall after 48 hours. You can do thyroid scanning. Remember, with technetium scintigraphy is better than radioactive iodine test because it is quicker to perform and it requires a lower dose of radioactivity. And ultrasound of the neck, which can show you single, multinodular, or diffuse goiter, right? To ascertain the cause, we do our thyroid autoantibodies. So for Graves' disease, we speak about the infamous TSH receptor antibody. All right. And also you can do antithyroid peroxidase and antithyroglobulin antibody, which happens to be very high in Hashimoto's thyroiditis, but only slightly to moderately increased in Graves' disease. Other tests you're going to do is an ECG in a patient who complains of palpitations because you don't want to miss atrial fibrillation, a chest X-ray which will help you to ascertain retrosternal extension of the goiter, if there's any cardiomegaly, a blood sugar as secondary diabetes mellitus can occur, serum cholesterol which happens to be low in thyrotoxicosis but high in hypothyroidism, do a fine needle aspirate if a goiter is present, and for ophthalmopathy you want to screen for that, right? Remember also that your pattern of radioactive iodine uptake is an ascertain the nature of what's probably the primary etiology, right? So if it's diffuse uptake, you're thinking about Graves' disease. If it's patchy uptake, it could be a toxic adenoma or toxic multinodular goiter. If there's no uptake, it's likely thyroiditis. Alrighty. List causes of thyrotoxicosis with a low radioiodine uptake. So that has to do with thyroiditis, be it subacute, be it postpartum, be it factitious thyrotoxicosis. It can be iodine induced in that the patient is on iodine or amiodarone, which contains iodine, or it could be an ectopic thyroid tissue producing the excess thyroid hormone in the way of stroma ovari, choriocarcinoma, or hyaluronic mole. Okay guys, how are we going to treat thyrotoxicosis? So there's basically three modes of treatment. There's drugs, there's radioiodine, and surgery. And under drugs we have two flavors, carbimazole and propylthiouracil. Okay, so essentially with drugs, how they act, how do these drugs act? They act by reducing the synthesis of thyroid hormone by inhibiting the iodination of our beloved tyrosine. So we can give carbimazole, the dose is 40 to 60 milligram daily per os. Once the patient is euthyroid, we can then reduce the dose to 5 to 20 milligram daily for a period of 18 to 24 months. Periodic full blood count should be done because one of the dreaded complications of carbimazole is agranulocytosis. Also, TSH and free T4 should be measured, right? The other drug option we have is propylthiouracil. The dose is 100 to 200 milligrams 8 hourly. The dose is also reduced once the patient is euthyroid. Now, to help with the dysautonomic symptoms, you can give a beta blocker in the way of propranolol up to a ceiling dose of 160 milligram daily, which does a lot to reduce the sympathetic symptoms such as tremor, tachycardia, and sweating. Okay, what are the indications for drug therapy? Nice to ask. It's usually given in the first episode in a patient who is below 40 years of age, if you have a small goiter, and if there are only mild features of thyrotoxicosis. The disadvantages of drug therapy is that there's relapse in 50% of drug therapy within 2 years of stopping the drug. In this case, you might want to opt for surgery or radioiodine therapy. Compliance may be poor, and remember, drugs are quite costly, all right? Complications of drug therapy, okay, the more common ones with carbimazole is that there's a hypersensitivity rash, and to circumvent this, you may commence your carbimazole at a lower dose and gradually up-titrate it. Of course, agranulocytosis happens in 0.1% of patients on carbimazole. The patient complains of a sore throat or fever. You must do a full blood count. You're going to find that the patient has indeed agranulocytosis. Stop your carbimazole because the patient can develop life-threatening infection. Nausea, vomiting, arthralgia, and jaundice are others, okay? Propylthiouracil is known to cause rash, nausea, and vomiting, agranulocytosis, hepatotoxicity. It does carry a risk for this, which is small but definite, and can have the potential to become quite serious, requiring liver transplant. So for this reason, it should be considered second-line therapy. It's only first line during pregnancy or breastfeeding because carbimazole is contraindicated during these times, or if the patient has intractable adverse effects with carbimazole. Okay, the second weapon in our armamentarium against thyrotoxicosis is radioiodine therapy. So how does this act? It acts simply by destroying functional thyroid cells and inhibiting their ability to replicate. It's effective in upwards of 75% of cases within 4 to 12 weeks. During this period, we give our beta blocker. In severe cases, carbimazole may be given 48 hours after radioiodine therapy. If it is given before 48 hours, it may actually reduce the efficacy of radioiodine. Contraindications, of course, we have to note that pregnancy or planned pregnancy within 6 months of treatment is a big contraindication. Lactation is a contraindication, and of course, if we have active or malignant Graves' ophthalmopathy, pray tell why? Because radioiodine can actually worsen Graves' ophthalmopathy and ophthalmopathy, right? What are the indications for radioiodine therapy? Usually it happens, or it may be considered when the patient is above 40 years of age. However, it may be used in the young, but the patient mustn't be trying to conceive, okay? Recurrence after surgery or drugs, irrespective of the age of the patient, can be used in toxic marshnodular goiter or toxic adenoma or so-called hot nodule. In early age with other major serious illnesses, in some cases of thyrocarcinoma, being it follicular or papillary post-surgery, ablative therapy with severe atrial fibrillation, also in heart failure, can be used in psychosis, those with poor drug compliance, and those who have drug hypersensitivity. Disadvantages of radioiodine therapy is that it can cause hypothyroidism in about 40% in the first year and up to 80% by 15 years post. This early discomfort and exaggeration of hypothyroidism may occur due to radiation thyroiditis. So the antithyroid drug should be given to render the patient euthyroid, and then should be stopped 2 to 5 days before radioiodine therapy. As we said before, radioiodine can exacerbate thyroid ophthalmopathy. Please note the following points. In severe thyrotoxicosis, initially carbimazole is given for 4 to 8 weeks. Then radioiodine therapy is given. Carbimazole must be stopped 48 hours before radioiodine therapy, and if there is no response up to 12 to 24 weeks post-radioiodine, you can consider giving a second dose of radioiodine therapy. In women of reproductive age, pregnancy must be excluded before you give radioactive iodine and avoid it for 6 months thereafter because of teratogenic potential. Men are also advised against fathering children for 6 months after receiving radioactive iodine therapy. The third weapon we have is surgery, and here we speak about subtotal or near total thyroidectomy. So here antithyroid drugs should be given to render the patient euthyroid before surgery. Potassium iodide should be added 60 milligrams 8 hourly just before surgery because it inhibits thyroid hormone release, reducing the size and vascularity of the gland, making surgery much easier. Indications for surgery, everybody? Well, if you've got a big old large goiter or a marshnodular goiter, which is cosmetically unappealing, right? Relapse or no response to drug therapy, drug hypersensitivity, poor compliance with drugs, suspicion of malignancy, pressure effects, and for cosmesis, all right? Complication of surgery is hypothyroidism in 25%, transient hypocalcemia in 10%. Why? Because you're pranging the blood supply to the parathyroids, okay? Permanent hypoparathyroidism in 1%, not that common. Recurrent laryngeal nerve palsy causing a hoarse voice due to vocal cord palsy. That happens 1% of the time. Please note that in toxic nodular or marshnodular goiter, the treatment of choice is radioiodine therapy and surgery. There is no role for carbimazole or propylthiouracil in the setting of toxic nodular goiter or toxic marshnodular goiter. Alrighty. So what is thyrotoxic periodic paralysis, TPP? So if a thyrotoxic patient develops sudden or periodic weakness, this is what we call periodic paralysis, and is attributed to hypokalemia caused by entry of potassium into the cells, is common among the Asian population. It may occur following excess carbohydrate or heavy exercise, which have links with it, and persists for about 7 to 72 hours. Treatment of thyrotoxicosis improves the condition. How are we going to treat thyrotoxicosis with atrial fibrillation? That's a good question, hey? So AF occurs in 10% of cases, common amongst the elderly above 60 years of age. More in toxic marshnodular goiter, may occur in subclinical hyperthyroidism as well. We treat it as follows. So you want to give the patient a beta blocker, right? So you can use propranolol, verapamil may be used if beta blocker is contraindicated. Then use the antithyroid drug followed by radioiodine therapy. Aspirin in the elderly, warfarin in the younger patient, you do a CHA2DS score. 50% of atrial fibrillation reverts spontaneously to sinus rhythm. If there's no response and AF is still persistent, give cardioversion, provided that the patient's T4 and TSH are normal. Alright, what is a thyroid storm? It's not happening in a thyroid patient when there's a storm outside. Thyroid storm is characterized by life-threatening increase in signs and symptoms of thyrotoxicosis, also affectionately termed thyroid crisis. The features of thyrotoxic crisis are fever, restlessness, agitation and irritability, nausea, vomiting, diarrhea, abdominal pain, tachycardia, atrial fibrillation, cardiac failure in the elderly, confusion, delirium, and coma. Precipitating factors for thyrotoxicosis or thyroid storm are infection, stress, surgery in a patient who is not properly prepared, and following radioiodine therapy due to radiation thyroiditis. So how do we diagnose this? It's mostly clinical, and the clinician should have a high degree of suspicion, and that is absolutely vital. Your free T4 and T3 and TSH should be done immediately. How do we treat this? Obviously, we take our samples beforehand. Then you want to admit to intensive care unit. You can give a beta blocker, and then we have propranolol, 80 milligrams 6 hourly, by a nasogastric tube if the patient is not swallowing. Intravenous fluid in the way of normal saline or dextrose saline. Carbimazole, the dose is 40 to 60 milligrams daily, or propylthiouracil, 150 milligrams 6 hourly via nasogastric tube, once again if the patient's obtunded and not able to swallow. You can give potassium iodide or Lugos iodine. Dexamethasone 2 milligrams 6 hourly IV and amiodarone are also effective. You can give a broad spectrum antibiotic. General measures to control temperature and oxygen therapy may be administered. After 10 to 14 days, once the patient is stable, you can maintain that patient on carbimazole alone. Alrighty. So guys, back to our clinical case. We had a 29-year-old male evaluated for anxiety, palpitations, diarrhea. He's known with Graves' disease. He also has chest pain. You order a CT angiogram, but the radiologist says we cannot do that. It is dangerous. Which of the following best explains why the radiologist is saying this? Drum roll, please. Dun, 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 dun. Ding. The answer is A. Iodinated contrast exposure in patients with Graves may actually exacerbate hyperthyroidism. So what's the rationale behind this, everybody? Patients with Graves' disease produce thyroid-stimulating immunoglobulins, right? These subsequently produce higher levels of T4 in comparison with the normal population, and as a result, many patients with Graves are actually mildly iodine deficient, and T4 production is somewhat limited by the availability of iodine. Now, exposure to iodinated radio contrast thus reverses the iodine deficiency, and it may precipitate worsening hyperthyroidism. Can't have that. Okay, everybody, I hope that you'll just allow me to encourage you about the eyes. Since we're talking about thyroid eye disease, what does Scripture have to say about the eyes? The book of Matthew chapter 6 verse 22 declares, the eye is the lamp of the body. So then, if your eyes are clear, your whole body will be full of light. In the book of 2 Corinthians 4:18, Paul says, so we fix our eyes not on what is seen, since what is seen is temporary, but what is unseen is eternal. Beloved, I hope that we will focus our eyes on eternity, right? Because what we see on this earth is just here for a moment and then it's gone, right? Life is just like a vapor, and I hope that we will consider eternity. And the book of John tells us, Jesus says, I am the way, the truth, and the life. None comes to the Father but by me. There is no other name given under heaven by which we are saved except in the name of Jesus Christ. So I pray that you will put your hope and trust in Him, and so He will see you through, and one day we will be with Him for eternity. Alright, so here are my references, and God bless you. Thanks for joining me. I'll see you soon with another handy video on my channel. Thank you so much.